Hello, and welcome to the Clinical Care Options Oncology Podcast. I'm your host, Tim Quill. Today's episode features Dr. David Kaplan from the University of Pennsylvania in the Corporal Michael J. Crescenz VA Hospital, and Dr. Tamar Taddei from the Yale School of Medicine and VA Connecticut Healthcare System. They will be discussing surveillance recommendations for hepatocellular carcinoma, barriers to implementation, and areas of investigation to enhance surveillance strategies. This episode is part of an educational program titled Understanding Surveillance and Screening Strategies in Hepatocellular Carcinoma, Expert Guidance in Clinical Strategies. For more information on the experts, along with a link to the complete program, including an expert commentary, please visit the show notes for this episode. Now let's get started and hear what the experts have to say.
Good afternoon. My name is Dr. David Kaplan. I'm a hepatologist at the University of Pennsylvania, where I serve as section chief of hepatology, both at the University of Pennsylvania and the Corporal Michael J. Crescenz VA Hospital in Philadelphia. And I'm joined today by Dr. Tamar Taddei from Yale. Tamar?
Hi, Dave. It's great to be here. I'm Tamar Taddei. I'm a hepatologist at Yale School of Medicine, and I'm chief of GI at the VA Connecticut Healthcare System. It's great to be here. Dave, we're going to be talking about HCC today, specifically surveillance. And I was wondering, to set the stage, if you could remind us all of what populations are the most important to bear in mind for HCC surveillance.
So we've focused on liver cancer surveillance in at-risk populations. And the threshold for defining an at-risk population generally is based on estimates of both effectiveness and cost effectiveness of liver cancer surveillance for detecting early stage liver cancer. And the thresholds that generally are used for patients with fibrotic liver disease generally set about 1.5% per year risk or greater, although there's some debate about perhaps that threshold should be a little bit lower, maybe closer to 1% per year. And for patients with chronic viral hepatitis B in particular, typically a lower threshold, somewhere around 0.8% per year, is usually used as the threshold value. And so the key at-risk populations are any individual with cirrhosis. And when we look across, cirrhosis can be caused by chronic viral hepatitis, alcohol, fatty liver disease, genetic liver disease, and autoimmune processes. Generally, for all of these conditions, although the individual risks do vary a little bit, almost all of these populations have a risk greater than the threshold for surveillance, and therefore are recommended to be in a surveillance program. And then among patients, as I mentioned, chronic hepatitis B, the risk of liver cancer evolution in patients with chronic hepatitis B is really a function of the duration of infection. And so individuals who come from endemic areas who have had infection for 40 or 50 years are those that are generally going to be at the highest risk and merit surveillance. And so our current guidance documents identify individuals who are from endemic areas, particularly Asia and sub-Saharan Africa, as candidates for screening. From Asian individuals, men over the age of 40, women over the age of 50. And due to an even higher risk at younger ages, we generally recommend doing liver cancer surveillance in individuals from Africa, generally at the time of identification of chronic infection. I start patients who are in their teens on surveillance if they come into my practice, just related to the very high risk of the combination of chronic hepatitis B and aflatoxin exposure in that population. Some particular populations that have to be specifically noted are those that are individuals with chronic hepatitis C, particularly now that we are curing these individuals of chronic infection. And generally, what we see is that patients who had cirrhosis from chronic hepatitis C, either if they were diagnosed with cirrhosis or have serologic evidence of advanced fibrosis using FIB4 evaluation. And I would throw into that individuals who had fiber scans that were in the advanced fibrosis stage or higher. Those individuals continue to have a long-term liver cancer risk that's at least 1% per year and should merit surveillance. And data that have been largely generated in part by our colleague, Dr. Georgie Iono at the University of Washington, has shown that risk persists out at least 7 years and probably longer after patients have been cured with infection. So once a patient has reached a cirrhotic stage with chronic hep C, even if the parameters suggesting advanced fibrosis improve during follow-up, we still want to keep those patients in a surveillance program. Another population that's a bit tricky to handle are patients with non-alcoholic fatty liver disease. This is a tremendous population, over 100 million American adults with fatty liver disease. We can't possibly do surveillance on all of them. What's clear is that the patients with fatty liver disease and cirrhosis should be in a surveillance program for liver cancer due to the risk that's related to cirrhosis. And it's a little bit harder to know what to do with patients who have advanced fibrosis or do not have any significant fibrosis with fatty liver disease, because a large fraction of the cancers that come out of the fatty liver population emerge from these non-cirrhotic individuals. However, when you look at it at a per person level, the risk for any individual patient with fatty liver who doesn't have advanced fibrosis or cirrhosis is so low that you really can't justify doing surveillance for those individuals. And even patients with advanced fibrosis who are not cirrhotic, the risk is probably below the threshold for cost effectiveness of surveillance. And so we really need to learn more about how to risk stratify the non-cirrhotic fatty liver population to optimize liver cancer surveillance. So we have a fairly good sense of which patients really need to be targeted for surveillance. But Tamar, can you describe for us our current surveillance paradigm and perhaps your vision of how that might evolve in the future?
Sure. So I think as we exist right now, our paradigm is ultrasound screening every 6 months or ultrasound surveillance. And the most recent HCC guidance from the AASLD has now definitively added AFP to ultrasound. So it's no longer plus minus AFP, it's ultrasound with AFP. And that should be done in all the populations you so aptly described. And the hope is that in the future, we may be able to risk stratify for many reasons, just the sheer magnitude of the populations you described. And obviously the somewhat alarming finding that a quarter to a third of patients with NASH-related liver disease may develop HCC in the absence of frank cirrhosis. But again, cost effectiveness-wise, in terms of the magnitude of the population, we really shouldn't be performing surveillance in them until we can risk stratify. So I'd say ultrasound every 6 months with AFP for all of the populations you described, with the hope that with future advancements in technology and understanding particular risks, we'll be able to risk stratify better for populations that fall outside those that you described.
The ultrasound plus alpha-fetoprotein is a fairly intensive regimen. What do you think are the biggest barriers to patients getting surveillance in the United States?
So this has been studied pretty extensively, both in the private sector and in the VA population. And there are many barriers to surveillance. I think the most important barrier from a population health standpoint is the fact that primary care clinicians don't necessarily know how to first suspect and then identify cirrhosis. And because cirrhosis is silent, this is a major issue. I think actually those folks who are in surveillance programs or recommended to be in surveillance programs, they all are just the tip of the iceberg. And actually the iceberg that lies below the water are those patients that have not been detected to have cirrhosis. And that starts with raising awareness. Once you get to the tip of the iceberg where we are, we know that even in patients who have cirrhosis, about 20% of them are in a sort of regular surveillance program in the private sector. The VA does a little bit better at around 45%. Part of that may stem from the fact that primary care providers and patients themselves don't know the importance of HCC surveillance and the risk of HCC once you have cirrhosis. So that's an important avenue to raise awareness. We know that when patients are referred to specialty care, they are much more likely to remain in surveillance. So I think that's another major plug for getting patients into specialty care. But clearly, this has to be part of the health maintenance routine for a patient with cirrhosis. The other issue is ultrasound. You have to have it scheduled. You have to show up. You need your blood work since we're adding an AFB. So I think these are all things that we need to make simple for patients. I think it's still a pretty intensive ask to have a person come for an ultrasound every 6 months. And I think in the future, we're all hoping that there may be other biomarkers that we can use. But for now, this remains the standard of care. And I think we have to do a better job at making this a more efficient program.
Do you have any thoughts about ways at a population level that health systems can implement systems to identify the patients with cirrhosis more effectively?
Yeah, so the VA does a very good job of this with something called the Advanced Liver Disease Dashboard, which is essentially configured to pull from the EHR specific parameters that would suggest cirrhosis. So the FIB4 greater than 3.25, as you mentioned, ICD codes for cirrhosis or hepatic fibrosis or risk factors for cirrhosis. So I do think that as we move into, modern EHRs, which have reams of data, that we can develop composite metrics to pull a de facto at-risk cirrhosis queue. That requires personnel, though. So personnel to build it, personnel to use it, and then personnel to follow through with those patients. And I think if you look at analogous models, for example, in cancer navigation for lung cancer screening programs and that sort of thing, getting people into screening and then, of course, making sure they come for recall, we have to consider all of these things if we were going to do this in a programmatic way. So there's a lot to consider there, but it's doable. And I think we're in an era now where it actually really lends itself well to being done. So that's a great question, David. I think it's an important one because, obviously you need to have metrics to see how you're doing. And I think the private sector metrics have all been pretty abysmal for well over 20 years.
I think we're at a point where many in the field are trying to identify ways of using the large electronic health record systems to implement population level screens for cirrhosis to try to increase the number of patients who ultimately get a diagnosis and therefore become eligible for surveillance. But it's still an early point, and we don't have a lot of data about implementation of these programs and the efficacy. It's often the idea is excellent and has a lot of promise, but implementation often faces challenges that we can't foresee.
Right. I think the other thing is it's not just that, it's also the uptake and the normalization of liver cancer screening. I think in the primary care world and even in the oncology world, this is not a hot button item like, say, breast cancer screening or colon cancer screening. And again, we're talking about an at-risk population, not an average risk population, which is really why the proper term is surveillance here. But you've seen how operationalized breast and colon cancer screening are. It's essentially you get a card, you get incentives oftentimes from your health insurance to get those screenings. And we have to raise awareness. So it's not just the infrastructure, but it's also the awareness that's a critical piece. And then, of course, studying the effects of those efforts to improve surveillance. But I guess we're talking here a lot about ultrasound and getting in and those types of barriers. Tell me a little bit about where you think biomarker development's going and how could biomarkers be used to improve the effectiveness of surveillance?
Biomarkers are an area of great focus in the field. And typically when we're talking about biomarkers, we're focusing on serological biomarkers, which can be obtained by blood tests alone that don't require necessarily a visit to a clinician, but can be done in a local lab in the community and reduce a lot of the barriers to access to the healthcare system. I think we can look at biomarkers in two large buckets. One are biomarkers that might risk stratify individuals in the potential at-risk population to those being at high risk and those that are perhaps at more modest risk. And then secondly, biomarkers for detection of early cancer. And so I think we can look at these in two different big buckets. In terms of biomarkers for identifying patients who are at risk from a larger population, we don't really have a huge amount of strong data, but there are some clues as to where that field might evolve. One is genetic biomarkers. And so there are individuals that perhaps might have a genetic predisposition for the development of cancer out of the cirrhosis population once they have cirrhosis. And there's been some work from a Franco-Belgian group, a German group, and now a VA group, which we presented some data at the liver meeting, that there do appear to be certain genetic factors that are associated with an increased risk of liver cancer among patients with cirrhosis. And perhaps over the next few years, those will be available, validated as risk stratification biomarkers for that population. The second at-risk genetic panel would be that patients with cirrhosis develop a large number of somatic mutations in the liver during the course of chronic disease. And there are many genes that perhaps represent cancer field effects, such as Wnt beta-catenin mutations, TERT mutations, that are potentially detectable in peripheral blood. And while they may not necessarily reflect an existing cancer, they might reflect an at-risk state among individuals and might identify those with cirrhosis who should undergo more intensive surveillance. In terms of serologic biomarkers, we currently have some available biomarkers that are being refined and several promising candidates that are undergoing prospective validation. The biomarker that has been used extensively for decades is the alpha-fetoprotein. But the problem with alpha-fetoprotein is that it has extremely low sensitivity. Typically does not increase until patients already have existing cancers, particularly with vascular invasion. And so it really is a late biomarker for most patients. And for that reason, its performance hasn't been suboptimal. Some newer biomarkers that have greater sensitivity include the alpha-fetoprotein lectin L3, which is a fucosylated version of alpha-fetoprotein that seems to be more cancer specific and also tends to be more sensitive than alpha-fetoprotein in some but not all studies. And so that is a biomarker that may be promising. Another one called DCP, descarboxyprothrombin, previously known as PIVKA2, seems to be similar to AFP in terms of its sensitivity, and the performance has not been optimal in validation studies. A more recent refinement of the use of these biomarkers has been to combine those with clinical parameters like gender and age, a calculation called GALAD, which is gender, age, the AFP-L3, AFP, and descarboxyprothrombin in a combined parameter that has been promulgated as a biomarker with perhaps an improved sensitivity. And we now have two phase 3 biomarker studies, one done by the HEADS Consortium and another by the Texas Consortium, that do suggest that the GALAD combined biomarker has better sensitivity than alpha-fetoprotein. It's still not optimal. We're still talking about sensitivity for any cancer in the order of about 55 to 70%, which is better than alpha-fetoprotein, but still not where we would like to see these biomarkers for use in the absence of imaging. So there's definitely more work to be done. And I think the most promising biomarkers that are being currently evaluated in prospective studies are those that are using newer and maybe more sensitive markers for some of these early precancerous and frankly cancerous changes. Fucosylated kininogen is one such marker that's being evaluated in prospective trials. And we're also now for the first time seeing panels that look at circulating tumor DNA for use in the surveillance setting. And it's too early to know how those studies are going to turn out, but hopefully in about 3 years, we will have some encouraging data from these new biomarker studies that are ongoing. And I think the hope is that at some point we can come up with a biomarker that can be done in your local lab. It doesn't require the patient to come in and have to engage with the healthcare system for ultrasound, because we know getting the patient into the doctor's office for more than one visit to see the doctor, to get the ultrasound, and to get the blood test. This is where there's big breakdowns in the cascade of care. So in terms of the development of these biomarkers, Tamar, maybe you can shed a little light on how biomarkers are developed and some of the barriers that we see in bringing these biomarkers from these early studies to market.
So as you mentioned, there have been a couple phase 3 studies. Biomarker studies are different than clinical trials. So there's actually 5 phases of biomarker development. And phase 3 is really retrospective longitudinal studies where you apply those biomarkers to a longitudinal cohort, often in retrospect. Phase 4 are prospective screening studies where you're actually enrolling patients and screening them prospectively over time as you move to the future, right? And then phase 5 is actually the most important and the hardest to reach. And that's really when you see a reduction in cancer mortality. So phase 5 is the holy grail. Phase 5 is when you've hit prime time, and it takes years to get to phase 5 because you actually have to do your prospective screening, validate it in different populations, and then show that there's a reduction in mortality. And so I think biomarkers are very different in terms of the way we approach them scientifically because the stakes are high, and you need to be sure that when you're screening a population, you're actually basing it on the validity of that biomarker. Now, you talked a lot about sensitivity and specificity, and certainly you can make allowances for either one depending upon the magnitude of the problem. And as we know, HCC is a highly lethal cancer, and the magnitude of the population screened. So I think it's just important to kind of think about biomarkers a little bit differently than we would about, say, randomized controlled trials where we're looking at efficacy of, say, a drug or that kind of thing. So the other thing that you're seeing is GALAT is a combination biomarker where you're taking in clinical factors as well as laboratory factors, and that may not be generalizable to other populations. All of these things need to be taken into account when deciding upon the validity of a biomarker for clinical use. So I think there's a lot to consider when you're thinking about biomarkers, but I actually think that the timeline that you mentioned, some 3 to 5 years, I think we actually will see some very exciting data. And we now really have a whole lot of different potential biomarkers in study, as you mentioned. So these aren't just, a laboratory value, but these are circulating tumor markers, they're methylation panels, they're all sorts of very interesting things. So I would say we should be very optimistic that we're going to have more tools in our toolkit, but also very careful that we implement biomarkers at the right time with the right validation.
So we've been talking a little bit about the paradigm of trying to move away from imaging to biomarkers to improve uptake. But one of the other parts of the equation is that ultrasound itself also has limited sensitivity. Tamar, you can give us an update on some new technologies that might improve the imaging surveillance component of our liver cancer surveillance combination.
So there are some exciting studies around using abbreviated MRI. Abbreviated MRI is a fast MRI. It's about 15 minutes. It is essentially taking a diagnostic test and making it a surveillance test. So essentially all of the sequences for a 15-minute abbreviated MRI would allow you to diagnose an HCC. And the VA is embarking on a large clinical trial to study ultrasound versus abbreviated MRI in patients with cirrhosis. And that's going to be a 9-year study to really answer that 30-year-old question of what's the best way to perform surveillance of these patients. I think ultrasound lacks sensitivity, and one could argue that it really depends on the body habitus of the patient, the user. It's user or operator dependent. And we perform ultrasound differently in the US than in other countries when it's actually done by the physician. We do ultrasound in the US by a tech. So a sonographer does it. So there's a lot that I think is wrapped up in that question. My hope is that we are able to use more sensitive imaging techniques, and certainly technology would suggest that these techniques will become more available and cheaper, as most things in technology do. But we do have to study it. So that's the basis of this clinical trial that I was mentioning.
So if there were a modest sensitivity serum biomarker that could be used widely throughout the community, or a high sensitivity imaging assay that would have lower uptake than a biomarker, at a population level, which would you recommend focusing on?
That's a tough question. I think at a population level, you'd have to focus on the less sensitive one that's more easy to broadly apply. And you could theoretically use that as a gatekeeper for the more sensitive test. So I think that would be wonderful if we could actually have biomarkers that maybe risk stratify those patients who should go on to an image-based test in a perfect world. But of course, that would take a lot of study. I do think we're talking about a much larger population at risk for HCC than we even understand. So I think in the interest of the greater good, we probably want a very easily applicable, accessible test for HCC, or at least risk for HCC. These are things that we grapple with, and we grapple with these things here in the United States. This is a very high resource country. And obviously, we don't have the lion's share of HCC. The lion's share of HCC is in other parts of the globe that may have lower resources. So we do have to think about this on a global scale as well.
And one of the things that often gets overlooked early in the development of surveillance programs is the harm associated with false positives. And the biomarkers that we currently are evaluating do tend to have a relatively high false positive rate, which creates a great deal of stress for patients and also leads to potential harms to patients in terms of perhaps unnecessary imaging, unnecessary biopsies that have some complication rates. What are your feelings about the harm of surveillance? Do you think it's something that is overstated, understated, or given the correct amount of emphasis?
I don't think it's been studied enough, really, in HCC. I think there are harms. I mean, imagine if you every 6 months get down on the gurney for your ultrasound and have in your head percolating the thought that you may have liver cancer. I mean, I think that could become psychologically onerous for some people. I think when you get into things like biomarkers where you don't have an image and there's risk there, but there's nothing on the imaging, I don't even know how to explain that to a patient. So these are very important things to study. And I think they are being studied in other domains. There's been a lot written on harms in lung and breast. So I think it's an important field of study in HCC, especially as we would surmise that things are going to become more interesting in the future with biomarkers. So I would say it's not studied well enough. I do think about harms when I counsel my patients. I have had harms in my patients. I've had complications of biopsy and things like that. So it's not trivial. And I think patients want to hear from us that we are considering harms, that we are actually thinking about how they feel when they come every 6 months for their ultrasounds. Dave, we've talked about a lot of different things, and certainly the field is hopping. I guess maybe to close, I'd love to hear from you what you think are the most urgent needs in the field.
Well, that's a great question. Besides the technological improvements that we've been talking about, I think the greatest need in the field is further recognition by other medical bodies in the United States, American Cancer Society, the United States Preventive Services Task Force, that liver cancer surveillance should be recommended. And we've, for decades, unfortunately, been floundering in a situation where in the absence of a randomized controlled trial that shows that liver cancer surveillance is effective, that we don't get endorsement by these broader regulatory bodies. And as such, we don't get emphasis from primary care on identifying the at-risk population and starting surveillance. And I think that's where the greatest need is actually having education of primary care that this is a priority and that these patients are particularly at high risk. The risk of liver cancer evolving out of a patient with cirrhosis is equivalent or higher than the risk of breast cancer evolving in someone with BRCA mutation, as one of our colleagues, Dr. David Ross, would opine. And yet we're in the BRCA situation, there would be very little resistance to starting surveillance. In cirrhosis, we continue to hit barriers. And so I think what we need is to find pathways to normalize and to endorse liver cancer surveillance in the primary care setting. How to get there, I'm not really sure how we would do that. But I think we need to push our national bodies to really move that forward, and may require legislative effort or other educational efforts to make that happen.
Yeah, I agree. I think it would give us traction that we need to really move the field forward. And it's something that we've been fighting for quite some time. That type of traction would really catapult all of these efforts that we talked about today. So it's been great talking to you, David.
Thank you.
Thank you very much, Dr. Kaplan and Dr. Taddei, and thanks to you, the listeners, for joining us. As a reminder, to view the full program, Understanding Surveillance and Screening Strategies in Hepatocellular Carcinoma, Expert Guidance and Clinical Strategies, and to access additional resources associated with this program from the Clinical Care Options website, please click on the link in the show notes. As always, thanks for listening.